So the first question, and it can be open to either one of you, is does a colonoscopy aggravate IBD symptoms? All right, the audience answer. Next one.
Well, so it's actually, so it has been studied in only one study that I'm aware of. I think University of Michigan looked at it in ulcerative colitis. And yeah, so they looked at, I don't remember how many people were in the study, and they suggested by not great parameters, but by looking at people who who were in remission at the time of the scope and who needed to go on to a medication after. And in that study, I think it was about 5% of people got worse. It's not, you know, a lot of people are having a scope done because they're not doing well, so it's more complicated, but that's the only thing that I can remember in terms of a good study that's done.
Yeah. I think it's always hard to say because you usually are doing colonoscopy because there is active disease, and how the two interact can be difficult to determine. I will say that in IBD there's also a proportion of individuals who have an IBS component or an irritable bowel component, so not inflammation, but more related to how the GI tract sense discomfort. And although this is only anecdotal in those individuals, it actually seems to improve afterwards, at least in the small population we have in Seattle.
I mean, I'll just add that, you know, we do colonoscopies more in adult GI than peds, because if you walk into our office, even if you came to the wrong office, we do a colonoscopy. But it's interesting because there was a study done, I think in Germany, it was a small number of patients, where they gave them something like, some phenomenal number, like 8 or 12 liters of Go Lightly, with the idea of, let's just wash out your microbiome, and can we totally just, and those people got significantly better. They may have also said, I feel great, I'm not going to come back here anymore. but I think that there have been studies done looking at the microbiome, not in people with IBD, but before colonoscopy, and then how long does it take for the microbiome to get back to normal? And most often it does. It takes, I don't remember exactly, 3-4 weeks or something like that.
It took me 4 to 6 months.
Yeah, so I think, but again, that's a complex interaction between your immune system and that, and also how much, you know, where are your reservoirs that can help repopulate things.
If you heal your microbiome with diet and have no symptoms for years, how do you get the disease again?
So you have to remember that in inflammatory bowel disease, it is related to the two components. Your immune system is a very important component, and even though the microbiome may change with dietary intervention, you still have the exact same immune system, and so you're apt to, your potential for developing inflammation doesn't necessarily go away. Another important component is with IBD and with any intervention, whether it's medication or diet, one can feel really good and still have inflammation. So it's important to remember that the two are connected, but not always. And so that's why it's important to not only evaluate symptoms, but also the inflammation itself.
Dr. Suskind, you've done some great work on EEN with pediatric patients. We hear too often that EEN doesn't work for adults because there's no studies, it only works for pediatrics. So maybe even Dr. Korzenik can share, does EEN work for adult patients as well as pediatric patients?
There's been a number of very good studies suggesting that it does work. It's not, we turn to it often as a bridge to something else. So if they're going to be starting a new therapy or they're really in a rough spot, and it's certainly much more user-friendly than TPN. So yes, there are good studies. It kicks in often as little time as a week or two. The problem is that I think you may have an easier time in pediatrics getting it covered, we have a hard time getting it covered. Maybe I'm wrong about it.
You're talking insurance
Sorry,
coverage?
insurance coverage to get that, because it's expensive.
Insurance will cover it if we have a nasogastric tube, but not if you drink it. They then consider it
Interesting.
diet.
So, not to get too political, insurance is a barrier to our care because it may not be compensated?
Yes. Yeah.
This is being recorded, correct? I think the complexity of the medical system is a barrier to good care in the U.S. and probably elsewhere in the world as well. Insurance does some wonderful things, but also can be roadblocks to getting appropriate care, whether it is dietary or such as EEN or medications.
What is your advice for balancing SCD, exercise, support, and IBD? Is that too much?
So I think that pediatrics may be ahead of us in terms of what are they called, life care specialists, or which we're sort of trying to do that now in adults and have a social worker and a mind-body program and other things. I think it's really a challenge because it involves so much, and everyone's lives are really busy. And if you didn't have IBD or other GI issues, you might not be spending any time thinking about this, and you just go on with your life. And the disease has its imposition, the diet does, and all the lifestyle things. So I don't have any. I think it's a matter of some people, if you jump in, do it all at once. How do you create healthy habits? Whole issue of establishing habits as opposed to I'm going to just try this and figuring out how to do it. I mean, it's much more than a quick answer. It involves really a broad sense of reevaluating how to do things and working with somebody. It's not something, the thing that with the SCD and with all of these things, too often it's saying, yeah, go ahead, do that. I don't have any problem with that. You can try that, as opposed to saying, here, these are the resources that we can refer you to. These are the people you can work with to try to make these changes in your life.
No, I agree. I think one of the dilemmas in medicine is that we don't have a good mechanism to improve all the areas that can affect a disease process. So in terms of sleep, life-work balance, school-work balance for my patient population. But they are important to address. I'm very lucky to be in an institution where we do have social work, psychology, nutrition, and other resources to help that life-work balance. But that's even in pediatrics, that's not always what's there. So when it's not there, I think what this is here, what the online community for SCD does is that support network, and is so important for the success for dietary intervention in IBD. Other support networks include obviously the Crohn's and Colitis Foundation, which does some wonderful work as well, specifically in pediatrics, has a Camp Oasis. So if you have a young child who has IBD, it's wonderful to have them go because it gives them community, and community strengthens the individual. So I would definitely recommend that.
Scenario: patient comes in, has the ESR test, the CRP test, and they're in normal range, but they have their fecal calprotectin test done and it reaches 500 to 1,000, but their CRP and ESR come back normal range. Why would there be such a high calprotectin test result? In a general sense, of course.
So some of it has to do with when you're in the medical profession, you realize that you have to be skeptical about all the tests that we do, whether it's even a colonoscopy or CT scan or an MR. There are limitations of how good all those tests are. So one of the reasons why we like calprotectin is because those other tests are okay. And if they're elevated and they come down, they tell you something. But as much as 40% of people with Crohn's can have activity, and this CRP can be normal. And so this calprotectin, a stool-based test, is much more specific and sensitive to tell us what's going on.
Could it be as simple as a false negative or false positive, or is that something to consider? I'm just asking.
Yeah.
Oh, no. With the sed rate and CRP, you definitely can have active inflammation and have normal levels. So that would be a false negative.
Okay.
Calprotectin, I agree. I like it gives us a little more sensitivity and specificity in terms of inflammation. There are things that can make it abnormal, including infection, and there can be interpersonal variation. So there's studies that show if you get calprotectin on the same individual but multiple times a day, you can have significant variation in that level. But if it's abnormal, that's telling you that there is still ongoing inflammation that is likely need to be addressed.
And minor thing to add there is so that in the not too distant future, we hope that there's going to be actually a home kit available for the calprotectin, so that lugging a stool sample into your lab is not necessarily people's idea of a good time. And so they've developed it. It's available in Europe. I'm not sure how far off it is in the United States, but it means you take a little stool sample, you shake it in the developer, you put it on the slide turns colors, and you take a picture with your phone, and then that goes to your physician, and you get a readout right away. It's not, there's studies being done for FDA approval to be able to use that, but that's coming soon.
Wow, great. How can doctors learn more about the specific carbohydrate diet to incorporate into the regime for their patients?
From you guys. So
Power of the people.
Power to the people.
Thank you.
There are definitely the way that I even learned was a wonderful family that didn't mind me driving to their house and looking at what they had in their cupboards and showing me the foods that they ate. So it really is through experience. And again, diet is a complex concept. And so the more one talks about it, the more one exposes your healthcare professional to it by just going to clinic visit and seeing that it's working can have a profound impact. Also, there are many online resources, Breaking the Vicious Cycle. I'll do a call out to Nimble and many others that make the educational process, I think, easier.
So what David just said is extraordinary, meaning that what he did when he heard about this patient. So a lot of people wouldn't be so open and to understand that. So one is, because most of your, well, maybe it is criticism, but that many physicians are not going to be so open and say, that's really interesting, I just heard what you said and I want to look into this more. So,
and I don't know if I'd invite every physician to your house. That might not be a good idea.
But so that's one route, and yes, you need to be the advocate and say, this is really helpful and we should talk about this more. The other thing, though, is studies. That's the sort of currency of what we do and generating data and understanding it, and so those are really important, whether it's being part of it, whether it's telling people about it, whether it's sort of helping in other ways.
You know, I don't mean to interject a question here, but you know, when I first started the Facebook communities, people would say, you know, why don't you be an SCD rep? Why don't you go to the GI offices and tell them, you know, about SCD, just like the pharmaceutical reps get access. Why don't we have an SCD rep that visits the GI offices? How do we get to them when the pharmaceutical reps are getting there before us? Of course, Massachusetts is a little bit different now, but you know, that's something that people asked, and I was like, there's just no way we could do that we wouldn't be invited. But it is interesting that you did bring that up. So, how do antibiotics affect the healthy microbiome of a child in Crohn's remission? Should I avoid giving my son antibiotics for illnesses unrelated to his Crohn's? He is exclusively on the SCD to treat his Crohn's disease.
So my grandmother died in 1942 before the advent of antibiotics. So yes, antibiotics are associated with development of IBD, but antibiotics are amazing and wonderful medications that are needed. So if somebody has an infection, you want to treat that infection. Letting that infection go is never a good idea. So yes, I do use antibiotics. If I can avoid using antibiotics because an infection is viral or not caused by a bacteria, then obviously I would avoid it. But antibiotics, even though they have some negative consequences, are also amazing medications.
What are your thoughts on the impact of GMOs and pesticides in our foods?
So it's hard. It's a very, very interesting question. I think everybody here knows I come from Seattle, so I, by default, eat organic. But I do feel that pesticides, we know that pesticides can get into the system. There are very good studies that show when you eat foods that have pesticides in them, the pesticides get into the body, into the bloodstream. The more difficult question is the negative consequence. So there haven't been studies per se that show a specific negative consequence or benefit to eating organic foods, but I am a non-betting person, and I think avoidance, if possible, is good. But there is not a large amount of data that I could show you to prove that. At least I don't have.
No, I would agree. I think it's sort of the broader question of all these things in our environment that we don't really have control over that may be detrimental. So we've been looking into a lot of environmental things. There are about 10,000 chemicals that we're exposed to probably on a daily basis. I mean, as one small example, this shirt, I think, is the type that I throw into the dryer and it comes out and it's pressed. It's a miracle. It's amazing. This is the way it does that is it's impregnated with formaldehyde, which is a carcinogen. Now, I don't think that I'm not sure I'm getting any systemically. Another example is we're doing some studies of what's in Miralax, PEG, for some other things. And so we want to see how it's absorbed by the body. Is it absorbed? And so you take some baseline water in your community just to say that's normal. Well, to our surprise, maybe I shouldn't have been surprised, there's some in the water. It's so many things are in that we're exposed to that have not been fully tested for safety. So how do we look at GMOs and other things? We don't know. I think that we're all tending towards saying if you can avoid it, that's better, but there isn't data to say it's detrimental in itself.
How does vitamin D influence the microbiome?
That's a good question. I actually don't know specifically how vitamin D will change the microbiome. I'm not sure if there are specific studies. You know, definitely vitamin D is or low vitamin D has been implicated as a potential factor in the development of IBD, primarily based on locations where IBD occurs more in the northern latitudes. But to my knowledge, I don't know of any vitamin D and microbiome data offhand.
I don't. I tend to very generously offer to have David answer the questions first that I don't know the answer to. So I don't know the answer. I would say that vitamin D is important in terms of influencing your immune system. So, and particularly how your immune system interacts with bacteria, at least for one genetic variant. So that it's it's not just your bones and other things, and it's, as far as I know, I don't know of any studies of direct implications for the microbiome, but maybe indirect through your immune system.
Can you discuss the prebiotic foods and the importance in choosing diversity of the sources of those foods, and probiotics too?
So I think the slides that have been shown in terms of the diversity of food, increasing the diversity of the types of bacteria in the GI tract kind of speak to themselves. The groups of people or the who tend towards a vegetarian diet just because of the difficulty in breaking down vegetables and fruits as opposed to simple complex carbohydrates really pushes the microbiome towards having a larger spectrum of bacteria that can break down that food. So in general, the more diverse food, the more types of bacteria you'll have that will be able to break down that food. And we associate that with a healthier microbiome, but I think as pointed out, we are still learning what a truly healthy microbiome means.
One of the things about the specific carbohydrate diet is the science of the diet that was written by Dr. Haas and later researched by Elaine Gottschall, and that was that bacterial overgrowth leads to inflammation in the GI tract. What's your understanding of that, or do you believe in that science?
So it's tougher to say bacterial overgrowth because I think when she was saying bacterial overgrowth, she meant it differently than what we think about it today.
Well, sure.
And so bacterial overgrowth today, we often talk about that in terms of larger amounts of bacteria getting into the small bowel. Those bacteria get to the food before you do, and they are breathing, and they're producing gas and other particles that are going to cause some diarrhea or bloating or other things. And that's slightly different. I think that, why that's become a bigger issue these days, whether it's because we have other tools to diagnose it, whether we're using more acid suppression, and the acid is really there to as an effective barrier against bacteria, not really to digest your food. And is that part of it as well? So we don't understand a lot of that part of the bacterial overgrowth. I think that what she was talking about in part was sort of also overgrowth of bacteria that is not contributing. And so even though she wasn't writing that long ago, I think that the concepts are evolving so rapidly that I think that my reading of her is that she was sort of referring in part to that overgrowth of bad bacteria as opposed to bacterial overgrowth.
Correct.
The way we use it in medicine today.
And you know, everything is evolving. Medicine is evolving, science is evolving, and the way we are looking at the microbiome is evolving, and we're getting much more focused detail, but it's extremely complex. And I think having general ideas of bacteria affecting the immune system, affecting the epithelial layer, the lining of the GI tract, all these concepts are extremely important, but the details are still being elucidated, because as human beings, we are extremely complex, and we even looking at that one molecule, the claudin 2 in Martinez Medina's paper, that's just one out of hundreds upon hundreds of different proteins that could be made. So kind of the underlying thought should be, we're on the right road, and yes, these issues matter, the microbiome matters, the mucosal immunity matters, but there needs to be so much more research. It needs to be research in clinical sciences, but also in the basic sciences. And I think those are being done, but it is a process.
Two last questions. Is there any correlation between Lyme disease and inflammatory bowel disease?
Not that I'm aware of. No one's demonstrated that yet.
Yeah, not that I'm aware. Lyme disease
Well, you're both from different coasts, so you
Right.
might treat differently too.
It
right?
is extremely uncommon on the West Coast. Another reason to come over to our side, it's much more endemic, I think, on the East Coast.
But there's no correlation as far as you're aware?
No.
And we have a lot of IBD on the West Coast as well.
Yeah, no, I know, but I understood that you may be treating it different.
Oh.
That's why the person asked. And just in your closing, both of you, without your presentations, what do you want to leave the group with? What words do you want to share with us? Words of wisdom, words of life experience, something that we can carry with us that will be above and beyond your presentations.
Well, I'll give you the last word. So I would say that somebody has pointed out that the amount of time that you spend with your gastroenterologist, if you have a GI disease, or your healthcare team, in the course of a year, may be a few hours when you put it all together. It may seem longer and waiting may be longer, but in terms of the amount of time you're actually spending there is very few, which means that 99.999% of the time, you're your own care provider. You're making the decisions every day of what to do. And you're also, what you're doing is really broadening out who's the care team. So it's not your doctor, it's not your doctor and your nutritionist, it's your doctor, it's your nutritionist, it's Jeffrey, it's the people sitting at your table, it's really learning from the community of what the broader wisdom is, and then making the best decisions you can. So I thank you for inviting me and commend you for doing what you're doing.
Thank you.
Saying ditto is not appropriate. No, I think what you just said was right on the ball. It really is about using the entire community, because you do just spend a very small amount of time with your healthcare practitioner, but utilizing all those individuals within your community, especially each other. I think from Seattle Children's, we've been very lucky to have a very strong community that bolsters each other and helps each other on the day-to-day. And that's what is so important in terms of doing dietary change and making lifestyle change. So I would point to community as the backbone of pushing forward with the SCD.
Can we give these doctors a round of applause, please?